So I think many people are aware that there has been, over the course of the last 15 or 18 years, a growing movement to expand the access to and the criteria for people receiving physician-assisted suicide and euthanasia, especially in Europe. And over that period of time, what's very remarkable about the countries, particularly Belgium and the Netherlands, to some extent Luxembourg as well, they have changed gradually the criteria for doctors to be able to legally assist their patients to terminate their lives, or to even actually administer the fatal injection to their patients. And the way in which the criteria have expanded are that no longer has it become limited simply to the terminally ill, which is in itself a very problematic term as to what the definition of that is, and it's also not entirely predictable. So they've expanded it from the terminally ill to the non-terminally ill, and they have taken away any kind of distinction between physical suffering and mental suffering, psychological, emotional suffering. You now have broadened the access to people who are not terminally ill and who have primarily or exclusively suffering in the domain of mental life, as opposed to traditional pain and physical disabilities. So you might well imagine that if you open the door in that fashion, stepping in line are going to be a number of people with psychiatric conditions. What has begun to happen in those low countries over there is that they have begun to have physicians either provide the means or administer the means to kill non-terminal, otherwise healthy, chronically mentally ill patients who have requested this service that the state now legally provides. Many of them are actually being killed in specialized clinics. Many of the hospitals now have euthanasia suites, including in Belgium. In the Flanders portion, there are hospitals where you can go into a wing, and on one side of the room is the electroconvulsive therapy suite, and on the other side of the room is the euthanasia suite. You have to absolutely go through a screening process in which several doctors have to declare that your case is both untreatable any further, which is in itself a very elusive concept in psychiatry, and that you, by some set of criteria, cannot suffer it, that it's insufferable and irremediable. And if in the Netherlands, you have to have, for a psychiatric patient, you have to have 3 doctors do that, at least one of whom has to be a psychiatrist. For non-psychiatric patients, it's just 2 doctors. In Belgium, it's 2 doctors. So the doctors will agree on this, and the patient will or will not be given permission to have the physicians basically fulfill their suicidal wish. As you might well imagine, this is something that really stands the fundamental definition and ethos of what it means to be a psychiatrist entirely on its head. I mean, we're the people who, both individually in our practices, as an organization like the American Psychiatric Association that's meeting this weekend, are very much devoted to the prevention of suicide. That is our method, that is our message. And in fact, we absolutely help people who are in dire straits of suffering, often very chronic suffering. But what our fundamental purpose is to, of course, try to ameliorate suffering. Okay? But if a person cannot be fully released of their suffering, as is often the case with many chronic conditions, to help them find a way to cope with the suffering, find a way to possibly, if there's residual suffering, even make meaning out of suffering, which human beings can and do, are capable of, and find ways to blaze a path to a better future. And it is so fundamentally core to our identities.